Medical oncology has achieved remarkable lifespan increases. A growing population now survive their primary tumors, power down the clinical apparatus, and enter long-term survivorship. But outliving the tumor often means facing a new set of metabolic risks. Treatment toxicity, altered body composition, and weight gain frequently lead to severe secondary cardiometabolic disease. Nutrition sits at the center of this challenge. It is a primary driver of post-treatment health variables, muscle mass preservation, systemic inflammation, and chronic comorbid conditions. Yet in standard clinical practice, dietary counseling is rarely integrated into the care plan. It is almost uniformly treated as an optional lifestyle suggestion, handed to the patient on their way out the door. Sustaining long-term health after oncology care is an incomplete task. We cannot solve it until we apply the same clinical rigor to post-treatment diet that we apply to chemotherapy protocols. A 2024 umbrella review published in the Journal of Nutrition addresses this gap. It aggregates systematic reviews and meta-analyses published since 2010 to examine exactly how diet affects cancer survival outcomes. The researchers mapped this evidence against the 5 major clinical guidelines currently used in the United States: the ACS, AICR, NCI, NCCN, and ASCO. The review asks 2 specific questions. First, do these 5 sets of institutional guidelines actually agree with each other? Second, is the epidemiological survival data strong enough to justify the advice they give? We are auditing clinical guidance to see where oncology disadvice backed by hard data and where it relies on broad extrapolation. This timeline maps a patient's clinical journey into 2 distinct phases. First is active treatment. Here, major guidelines avoid rigid dietary targets. Instead, the focus is entirely pragmatic. Prioritize weight maintenance, manage treatment-related symptoms, and prevent the loss of lean muscle mass. The American Cancer Society provides the most operational detail, explicitly mandating continuous malnutrition screening and early escalation to nutritional support when oral intake drops. Once entering post-treatment survivorship, the guidance shifts. Here, disparate institutional pathways converge into a surprisingly unified consensus. All 5 guidelines effectively repurpose a standard cancer prevention model. They recommend a heavily plant-forward diet, low in red meat, strictly limiting alcohol and ultra-processed foods. This unified approach gives patients clear behavioral targets. However, it relies heavily on general chronic disease prevention principles, rather than offering metabolic precision tailored to specific cancer types. To understand this consensus, we must look at the evidence. This matrix charts dietary factors against survival outcomes, showing where data is reliable. The highest fidelity signal sits right here. Healthier overall dietary patterns strongly correlate with lower all-cause mortality. Researchers quantify this using standardized scoring systems, like the Healthy Eating Index or adherence metrics for Mediterranean-style diets. These findings are particularly robust in breast and colorectal cancer survivor cohorts, where the bulk of current observational research is concentrated. Conversely, survivors in those same cohorts who adhere to a standard Western diet show significantly worse all-cause and cancer-specific mortality rates. The data shows that a patient's overall dietary architecture, the holistic structure of their daily intake, is a stable predictor of survival. The benefit comes from the whole, not from isolated variables. Yet clinical discussions often zoom in on specific micronutrients. Patients frequently ask about adding vitamin D, soy isoflavones, or fiber to target their disease. When we evaluate isolated nutrients, the evidence for mortality reduction or fractures, the data becomes thin, contradictory, and fails to replicate consistently across different cohorts. Furthermore, data linking specific dietary factors to preventing disease recurrence is remarkably weak across all tumor types. The umbrella review applied the AmStar 2 rating system here, revealing that meta-analytic data driving single nutrient claims is of low or critically low methodological quality. We also have to account for healthy user bias. Survivors who maintain high diet quality often have better socioeconomic status, access to healthcare, and consistent exercise habits, which heavily skews observational results. Diet undeniably correlates with survival. But isolating a single food as an independent causal determinant is nearly impossible with observational data, making single nutrient prescriptions scientifically baseless. While the science of survivorship nutrition has stabilized, the clinical architecture to actually deliver that advice has not. Implementation faces rigid systemic barriers, a severe lack of clinician time, inadequate nutrition counseling reimbursement models, and intense patient financial toxicity. Under these conditions, handing a survivor a generic, printed dietary pamphlet is almost guaranteed to fail. Expecting patients to independently adopt and maintain complex, plant-forward dietary changes without structural support is a flaw in clinical design, not a failure of patient willpower. This flowchart illustrates a tiered approach, integrating nutrition into oncology. Tier 1 establishes a baseline. Survivors receive advice focused on broad, plant-forward dietary patterns. Tier 2 routes high-risk survivors directly to dietitian referrals and active interventions like medically tailored meals. Oncology must stop waiting for perfect randomized clinical trials on single isolated nutrients. We need to build systems that make healthy eating a tightly integrated, feasible reality for survivors.